Thank you so much, Dr. Farzaneh. It was very thorough. Thank you, so insightful. So now we've just completed both our presentations and we're in the question section of the webinar. So if anyone has any questions, feel free to submit them in the chat and our speakers will do their best to answer. To start off, I go over to Dr. Ambach and just kind of for beginners who are just starting off in the lumbar spine injection field, what are the most common mistakes that you think that they could avoid or things that little pitfalls that may pop up?
So I think especially for spine patients, I think the most common thing that we need to remember is to set patient expectations, especially for chronic spine pain, chronic low back pain. There's multiple pain generators. Sometimes there's psychosocial components that are involved. Patients come into you and they think that you're going to resolve their disc bulge. They think that you're going to regenerate their discs, and they think that you're going to get rid of their arthritis. And so you're going to have to set expectations with regards to what to expect from the treatment. How long will it last? When will they start seeing the effects? It's not immediate. Some of them will be calling you in 1 week and say, "Why am I not better?" Um, and to tell them that it's probably going to be not not just a one session injection, especially for these patients who have multiple pain generators, wherein they might need boosters down the line in a year or two, or they might even need a series of injections. And so setting patient expectations for me is the main thing. And then obviously there's a lot of different factors, but that's just kind of one thing that you need to think of when you're talking to your patients and trying to formulate that plan in your head with regards to what biologic to inject.
Okay.
I think we lost our host here.
Yeah, let me continue that. So there is a question: is ultrasound guidance PRP injection an option rather than using
CR.
CR?
Yeah, so in leaner patients who's got a lower BMI, you can actually see their facet joints really nicely. You can do an intra-articular facet joint injection with ultrasound. You can do your supraspinal, interspinal ligaments. You can do your paraspinal muscle injections. You can do your SI joint injections, SI joint posterior ligamentous complex using ultrasound. You can also do a caudal epidural injection using ultrasound very easily. It's kind of hard to do a transforaminal epidural injection using an ultrasound. You just need that contrast to make sure that you're not vascular. Still the standard of care overall to use fluoroscopy, but there's definitely some pros to using ultrasound, especially in leaner patients. When patients are, have higher BMI, it's kind of hard to do ultrasound guided injections in the spine. Okay, so there's a question here with regards to Wharton's jelly. These are allogeneic treatments that's derived from birth tissue products. These are still illegal to use in the United States. And so I'm not aware if there's very limited studies on its use for the spine. And so these are not being used in the spine at this moment. Most of the biologics that are used on the spine is PRP and autologous MSCs, with the source being bone marrow concentrate. Even MFAT is very limited in the spine as well. There's one study of using SVF and PRP in combination to the disc, but that's about it that I know. that are same day injections. All the other studies are probably in the cultured cell category. Yeah, I mean, the most common injections that we do for the spine is the epidural injections, the facet injections, um, and SI joint injections. Entirely a presentation on its own is the intradiscal injections. And so that might be, a whole other topic to discuss, but it's really the main thing to formulate in your mind is the plan on which structures to inject. And then once you have listed out all the structures that you wanted to inject, then you have to determine your different PRP bioformulations. And that way you would know how much to do blood draw. You can set up the time and just kind of plan out that whole procedure time because it can be a little bit more complicated, especially with the spine.
Okay. There is another question. Is combination therapy with prolotherapy, corticosteroid, and PRP recommended?
So corticosteroids in combination with PRP, no. They're kind of doing two different things and they're counteracting the effects of each other. The only time that I do use very rarely steroids in the spine is if a patient comes in with a very, very hot radiculopathy, they have a life event that they need to get that relief right away. Although some would argue that you can still get an immediate relief with a leukocyte poor PRP or maybe a platelet lysate PRP with a really, really toned down version. And when I say toned down, more of the nanodose formulations of dexamethasone to kind of stimulate growth factors, but no role for steroids and PRP in combination. There are some practitioners that do a prolotherapy as a pre-treatment prior to the PRP injection, and that probably is more acceptable than using steroids.
What is the normal interval therapy in using PRP in the back? What is the most common retreatment?
Treatment cycles. Yeah, so typically what I do is I do a functional spine unit approach because most of the patients don't really see the maximum benefit from these treatments until about maybe 3 to 4 months. Some of them will even be delayed up to 6 to 8 months. Usually I let them come back in about 3 months, 2 months, 3 months or so. And then if depending on where they are at the time, then we can plan to do a repeat procedure at that time. Unless we are staging, the treatment options, I rarely do have them come, every week or every 2 weeks for a series of injections. I do have a hemocytometer on site, and so I know that if I have a good platelet dose, then these patients do well with just one session of multiple target injections.
Question about the charge.
This is very variable on number one, how many structures are you injecting? Is it, a one level? Is it a two level? Is it limited? Is it comprehensive? And then also, are you injecting the discs? Wherein most of the cases for intradiscal injection, you're going to use a conscious sedation, which can add to your price. Are you doing it in your clinic? Are you doing it in a surgery center? Again, which will all add to the cost. But typically for a spine, let's say spine procedure, that's anywhere from a 3,000 to a 10,000 cost. It just really depends on how many injections and how many structures are you injecting and what kind of biologics you are injecting. We got Natalie back.
I'm so sorry, guys. A little bit of
It's
technical
okay.
difficulty there. Yeah, sorry about that. So we're a little bit over, but maybe one more question and then
Yeah.
we can continue. Okay. So I think I had a question about the approaches as far as when you're doing the injections. What are the factors that come into play when you're choosing between like a different approaches? Like, let me see, I'm not that familiar with the medical terms, but like the caudal versus I know all the others that you do.
Yeah,
And
yeah. So I
what
think
you
your question was what approach to do in an epidural injection.
exactly, yeah.
The two most, well, there's three approaches to do an epidural injection. Either you go transforaminally, wherein you inject through the openings on the side of the spine, or you do interlaminar injection, where you go central midline, or you go a caudal approach, wherein you go to the sacral hiatus. So the most common injection that's being used is a transforaminal approach because it gets you closer to the nerve roots. It gets you closer to the disc structures. It's more specific with regards to getting the biologic to the specific nerve root that you want to target, especially if it's a one-sided kind of radiculopathy symptoms. So those are the most common. That's the most common injection. The interlaminar is helpful for those patients who's got bilateral symptoms and they have a good, adequate spinal canal space into that posterior epidural space to perform the procedure. It's an easier injection to do because it's one injection versus multiple if you're doing transforaminal injection. And then you can also do your interspinal ligament injection at the same time. Caudal epidural is less sensitive. I call it the shotgun approach because you can cover as much structures as you can, usually up to the level of L5, maybe L4 with the caudal epidural. You have to inject higher volumes. And I usually use that when the patient's symptoms are more in the sacral level, kind of L5 level of symptomatology.
Okay, thank you so much. Oh, and we have a question from Ken Krusky. If you give a steroid injection and then you later choose to do a PRP injection, how much time do you allow?
Yeah, I typically allow 4 to 6 weeks in between. Some physicians are more conservative, do wait a whole 2 months before doing a biologic injection after a steroid injection. But I do 4 to 6 weeks.
Okay, thank you. So I think we can end there unless anyone has any last minute questions. Thank you everyone for your time. And if I could just grab 2 minutes just to go over some brief announcements, I will do so very quickly. Let me share my screen. Here we go. Um, let's see. Okay. All right. Can everyone see my screen?
Yes.
Yes.
Okay, great. So we have an upcoming event, Precision in Motion Conference. It's happening in May, and you can register through the Gulf Coast Biologics website. The topics that are going to be covered are adipose harvesting, bone marrow aspiration, nerve hydrodissection, spinal injections, and ultrasound guided injections. And the conference will be held at the Gulf Coast Biologics Training Center in Fort Myers. These are the panel of esteemed speakers and folks who are going to be doing the training. We have Michael Meng, and he'll be doing spine injection workshops. We have Sina Farzaneh, who you just heard from, and he's going to share more of his insights on formulations and mechanisms and all those underlying pathways that are mystery to most of us, but seen as an expert in them. And then we have Dr. Miller, who will be telling us more about adipose harvesting. There's Dr. Rowan Paul for nerve hydrodissection, and Dr. Moses Irizarry Roman for BMA aspirations. So the conference is $1,500, and if you're an M-Site product user, you get a discount, a substantial discount. It goes down to $950. Just call ahead before you register, and you'll get that discount. Another big plug, free ultrasound training, also at the Gulf Coast Biologics Training Center. Leslie Aja, a diagnostic sonography specialist, does these, and you just register also through the Gulf Coast Biologics website and set up a training. And again, I should mention it's free, so no reason not to take part, to take advantage and get your free ultrasound training. And so MSite has an app. It's the Power Sales app, and it's fantastic. I have it on my phone. You use it to order. You can use it to file customer complaints. You can use it to do platelet yield calculations and platelet concentration factor calculations. It's very handy. You can use it to register also, I think, for free MSK training sessions. And also, you can register at no cost to use the MSite Data Biologics. So it's very handy. There are other resources. Definitely worth downloading it and checking it out. And
think we lost you, Natalie.
Okay, we don't have Natalie. Fortunately, probably she has a problem with her laptop. Thank you so much all joining us for this session of Regenerative Edge. We're going to have our next one in about a month, so we will we'll let you know about the next topic. Again, thank you for supporting us. You have a wonderful, wonderful evening, and thank you so much.
Thank you.
One thing before everyone goes, if you have questions on transitioning from pure PRP to a Spiridome, let me know. I've had, I don't know, several hundred of them now, and it's a game changer technology as far as platelet yield. So just reach out to me. So
Perfect. Thank you so much.
have a good evening. Good job, Mary.
Thank you for joining us in this session of MSite's webinar series. Stay tuned for our next episode as we continue uncovering the science behind precision biologics.